Welcome to this first in a series of monthly free webinars organized by Healthy Heart Charity, the Cardiovascular Research Trust. This webinar provides updates on hypertension and has been held in partnership with Medical Society, the Fellowship of Postgraduate Medicine, which publishes two international journals, the Postgraduate Medical Journal and Health Policy and Technology. I am Donald Singer, Chair of the Cardiovascular Research Trust and President of the FPM, and our speakers today are Professor Bernard Cheung from University of Hong Kong and Professor Albert Ferro from King's College, London.
Thank you very much, Donald. Well, this is a subject very close to my heart because hypertension is a very common condition, as we all know. It has been estimated that there are more than 1 billion hypertensives in the world today. The prevalence of hypertension varies from country to country, of course, depends on the age of that population and how you define hypertension. But usually the prevalence ranges from 25% to about 50%. So it's a huge problem. And of course, hypertension is a major risk factor for cardiovascular disease. So when you're young, you have risk factors like hypertension, hypercholesterolemia, diabetes, and smoking. And in the course of decades, the atherosclerosis will develop, and you have coronary artery disease leading to heart attack and heart failure, etc. Now, in recent years, there have been a number of international guidelines on the management of hypertension. So back in 2014, JNC8 was published. And the thing about JNC8 was that hypertension, the target for blood pressure control in the elderly was raised to 150/90. So that was quite controversial at the time because there were studies showing that the elderly hypertensives who received a lot of drugs suffered from dizziness and falls, and so their blood pressure target was raised in the JNC8. And then 3 years later, another American guideline, the AHA-ACC guideline, lowered the blood pressure target to 130/80 as a result of this SPRINT trial. And then a new category of stage 1 hypertension was defined. And these people have a systolic blood pressure between 130 to 140 and a diastolic blood pressure between 80 and 90. So they have mild hypertension, and this new category of stage 1 hypertension was defined. And then in 2018, there were the European guidelines, which, characteristic of European guidelines, they tend to be a consensus guideline, a compromise, some amalgam of previous ideas. So in the European guidelines, the definition of hypertension remains at 140/90 or above, whereas the target blood pressure was lowered to 130/80 if the patient could tolerate treatment. And then in May 2020, last month, the International Society of Hypertension published their guidelines. And there's something quite new here. Well, first of all, because it's an international guideline, it's supposed to be applicable globally. And so it caters for both rich countries as well as poorer countries. And so they set really two goals, optimal goals and also essential goals, especially for countries with low resources. So for the countries which don't have the resources, then the target blood pressure is less than 140/90, or at least lower the blood pressure by 20/10. Whereas if you want to aim for optimal treatment, then the target is less than 130/80 for people younger than 65, and for the elderly, i.e. people who are 65 years old or older, then the blood pressure target is 140/90. But you need to consider issues like frailty, independence, and tolerability. And interestingly, um, you're supposed to aim for blood pressure control within 3 months. So don't start with monotherapy and then increase the dose and then add another drug and all that. So try to aim to get the blood pressure under control within 3 months. So that's sort of at least one school of thought. Now, going to the main theme of my talk, which is why I think non-pharmacological treatment is very important. I think it's both essential and optimal. It's because for resource-poor countries, non-pharmacological treatment saves money. But even in resource-rich countries, non-pharmacological treatment will improve blood pressure control and also health outcomes. People with stage 1 hypertension, i.e. those with quite only sort of slightly elevated blood pressure, should have non-pharmacological treatment in the first instance, unless their cardiovascular risk is high. Now, non-pharmacological treatment, you might argue that perhaps its effectiveness is limited, and sometimes it may not even be cost-effective. However, it is, I think it's fair to say that it is nearly always safe. Now, back to this category of stage 1 hypertensive patients defined by the American criteria. We've actually looked at the characteristics of these people. Only 2% of them have a history of cardiovascular disease. So definitely, these are people at the early stage of the cardiovascular continuum. Only 2% of diabetes. The average blood pressure is 129/77, which is really rather unremarkable. And the only reason why they're classified as hypertensive was because either their systolic blood pressure was higher than 130, or their diastolic blood pressure was higher than 80. So, it's an either or. So if one of those measures went above the threshold, then they were classified as stage 1 hypertensive. 80% of these stage 1 hypertensives are younger than 60, and 80% have abdominal obesity by IDF criteria, meaning it's really American criteria for abdominal obesity. 17% are smokers. So if you look at the profile of these patients, you'll see that really most of them require non-pharmacological treatment rather than pharmacological treatment, because they have only mildly elevated blood pressure, they're young, and they are at low cardiovascular risk. And of course, 17% of them have one thing that they can easily check. Well, perhaps not so easily, but something that they really should change. So here are the 5 main things you can do to your lifestyle to lower blood pressure: weight reduction, the DASH diet, low sodium diet, physical activity, and moderating your alcohol consumption. So if you add them up, it's actually it's very effective. Now I'm going to talk about each of them in turn, except alcohol consumption. I'm not advocating our patients to take up drinking alcohol. It's just that for those who are already drinking a lot of alcohol, they really should moderate their alcohol consumption to a something like 1 or 2 glasses a day. Now, I'm very pleased to show you some data on British schoolboys. It's a very small study of something like 60 schoolboys. But you can see that actually there is a very strong correlation between the systolic blood pressure and the waist circumference. In this group of youngsters who obviously none of them were on antihypertensive treatment, and I don't imagine many of them were, let's say, drinking a lot of alcohol and all that. So it's a fairly unconfounded group. And in contrast to the effect of obesity, the effect of exercise was rather small. So for those people who exercise more, yes, their blood pressure was somewhat lower. And also, of course, blood pressure rises with age, but then again, this is only a modest effect. So by far, the correlation was biggest with obesity. Now, what about the healthy diet? Well, it's known as the DASH diet in the United States, the Australian diet in Australia, the Californian diet in California, the Mediterranean diet in Europe, and the Nordic diet in Scandinavia. So basically, it's what one understands by a healthy diet. So lots of fruits and vegetables, whole grains, low-fat milk products, and lean meat, and plenty of nuts, and using olive oil and all that. So that, I think we all recognize that as healthy diet. What one might call, the diet in the muesli belt in Britain. Now, for those foods on the right that really should eat less of, then there are the sugary products, the high-fat products, the white bread, fast food, and alcohol. So the sort of things that you can get in the high street easily. Now, there is a relationship between sodium intake and blood pressure. I think we all understand that. And historically, it was first identified using population studies as in classic studies by Dow, and also the famous Intersalt study. Note, however, that actually the relationship between blood pressure and the 24-hour urinary sodium excretion, which is a marker of sodium intake, that relationship was actually wasn't very strong. And in fact, if you exclude the four condescendingly called trides, then tribal sites, then really the relationship between blood pressure and sodium intake is not very strong. Now, when a 24-hour ambulatory blood pressure monitoring came along, then it's much easier to show a relationship between sodium intake and the ambulatory blood pressure, as you can see in this Italian study. And on the left is actually a study that I conducted some years ago. So actually, it's quite easy to show a relationship between the two. Nevertheless, the effect of salt restriction is only modest, perhaps equivalent to taking one antihypertensive drug. And now, in the East, it's actually possible to reduce the salt intake from very high to very low, because presumably some people actually eat a lot of salt and dip everything in soy sauce and all that, whereas it is quite possible to gradually change to a low-sodium diet in the Far East. Next, I want to talk about physical activity. And of course, we all know that regular exercise will lower blood pressure. But I want to show you some recent data that we have published. And to me, it's quite astonishing, really, because for people who don't do any, who have no physical activity at all, well, the mortality over some 10 years was something like 6%. However, if you look at the group who have leisure time physical activity, then they have a markedly lower mortality. And leisure time physical activity is more important than occupational physical activity, i.e., the physical activity you have during work. And so regular exercise is good for you. Of course, this data is confounded by the fact that, for those people who are not fit because of illness, they're not, obviously they cannot exercise very much. And so there is confounding here, but still the association is very striking. So if you can at all exercise, it's a good thing. It's a marker that you are cardiovascular, you are sufficiently fit in terms of the cardiovascular system. So all in all, you can see that if our patients can institute all five, or even if several of these five things, their blood pressure will be substantially lowered, and each one is almost equivalent to taking one antihypertensive drug. Now, of course, in reality, not everybody can carry out these lifestyle modifications, but if they succeed, then it's really well worth a try. And on that optimistic note, I would like to finish my part of the talk.
Bernard Cheung, thank you very much indeed. A key question we may come on to is the extent to which you can pick and choose lifestyle measures, and also ways in which they may complement pharmacological and other treatments. We shall now hear from Albert Ferro, who is a professor of clinical pharmacology at King's College London. Professor Ferro will discuss underlying causes of hypertension, available medicines and how to use them well together, and newer devices which are under discussion for patients with more severe hypertension.
Yes, thank you very much, Donald. And thank you for your forbearance with this. I had some security accessibility issues on my computer, which I think I've now resolved. Anyway, thank you for inviting me to talk, and thank you to Bernard for that really very good and comprehensive introduction. And I'm going to go on from where Bernard left off and talk a little bit about pharmacological treatments, much of which I'm sure will be familiar to a lot of the audience here. I'm also going to touch on other things. I'm going to touch on areas of hypertension where there's a secondary cause which can be tackled. Where you can treat the hypertension by treating the underlying secondary cause. And I'll finish off with a few words about some device treatments of hypertension and where we are with that. These are my disclosures. I'm funded by the BHF for my research, no honoraria, no shareholdings, and no speaker bureaus. So you've heard about some of the international guidelines that we have. You've heard from Bernard a good selection of them. And this is what is generally used in the UK, which are the NICE recommendations from 2019. You'll have seen from Bernard's talk that the recommendations do vary considerably from one international guideline to another. And this is what NICE recommends, that basically the target blood pressure should be less than 140/90 by and large, unless you're very elderly, in which case it's 150/90. If you are using ambulatory or home monitoring, then there's a correspondingly lower target, which is 135/85 for most people, or 145/85 if the patient is 80 or older. And of course, there are certain situations where you would want to be certainly more rigorous. You'd want to get to lower pressures, specifically in diabetics and patients with chronic kidney disease. You've heard about lifestyle measures and the effectiveness of those and the usefulness of those, especially in those with milder hypertension, where the cardiovascular risk is relatively low, and where the use of medication you would try to avoid if at all possible. But if you have somebody with more severe hypertension where the lifestyle measures aren't working in themselves, then in that situation you may go on to medication. And these are the current NICE recommendations for how to use medications for hypertension. They are based essentially on age, ethnicity, and presence or absence of type 2 diabetes. Age on the grounds that younger people tend to have high renin hypertension, whereas older patients tend to have lower renin hypertension. And so in the younger patients, drugs which block the renin-angiotensin-aldosterone system are more likely to be effective, whereas in older patients, those which are either diuretics or calcium channel blockers are more likely to be effective. Ethnicity, because patients who are Black African or have Afro-Caribbean family origin are again more likely to have low renin hypertension no matter what their age. And the reason for diabetes, type 2 diabetes, is that we know that whatever your renin status is, if you're type 2 diabetic, you're at risk of diabetic nephropathy, and the ACE inhibitors and the ARBs, the angiotensin receptor blockers, are particularly effective in delaying the either onset or progression of diabetic retinopathy. So for the diabetics, ACE inhibitors or ARBs are first line, and then depending on age or ethnicity, if you're not type 2 diabetic, then either an ACE or ARB or a calcium channel blocker first line. A lot of people these days, particularly in view of the recent ESC, ESH recommendations, would actually go straight to step 2. And what the ESC, ESH recommend is that the majority of patients who require pharmacological treatment should probably be started on a combination of 2 drugs. And that kind of makes sense because you know that the majority of people will actually need 2 drugs to reach modern targets. And so a lot of people would go straight to step 2, combining an ACE or ARB with either a calcium channel blocker or a thiazide-like diuretic. And then step 3 would be combining an ACE or ARB with a calcium blocker and a thiazide-like diuretic. So that's 3 drugs, including a thiazide-like diuretic. And then the question has been for a long time, what do you do at step 4? When you're still not achieving target blood pressure, what is the next drug that you should add? And now there's a fairly clear view, a fairly clear consensus, I think, that the drug of choice in most patients for step 4 would be low-dose spironolactone. And that would be the case if your potassium level is relatively normal. If your potassium level is slightly high or borderline high, or if there's a question about renal function, then you may avoid spironolactone and go instead for an alpha blocker or beta blocker. And at that stage, you may want to get expert advice from a specialist hypertension clinic as well. So spironolactone for the majority of people at this stage, and that recommendation is really based on this study, the Pathway 2 study, which was published back in 2015. And in this study, patients with resistant hypertension, so on 3 drugs, but who still had high blood pressure, were then randomized to receive, on top of their existing therapy, placebo, spironolactone, doxazosin, or bisoprolol, and they rotated through those treatments in random order. And this is the important graph that comes out of all of this, is the effectiveness of spironolactone as add-on therapy. You can see actually that placebo in itself actually has quite a good and marked effect on reducing blood pressure on top of existing therapy, which is quite interesting. But then on top of that, you get an added effect of doxazosin, which is an alpha blocker, or a bisoprolol, the beta blocker. But the most effective of all was spironolactone, as you can see here, especially so on systolic blood pressure. And this shows that this was true throughout the spectrum of patients' renin levels. And you can see the lower the renin level, the more effective the spironolactone was in reducing blood pressure. So spironolactone's effect is shown in the red line here, and then we've got doxazosin in the green, bisoprolol in the blue. So on the x-axis, we've got renin, and then on the y-axis is the change in home systolic blood pressure. And you can see that at pretty much all levels of plasma renin, spironolactone was more effective than either of the other 2 drugs. And the lower the renin, the more effective the spironolactone was. This might partly be explained on the basis that spironolactone is very good at treating primary aldosteronism. And in primary aldosteronism, of course, you have low renin, high aldosterone. But more important than that, actually, is the fact that low renin is also indicative of sodium retention. And this is kind of saying that in these patients with resistant hypertension, sodium retention is likely to be a very important factor in their hypertension resistance to therapy, and that addition of further diuretic is going to be of beneficial effect. Now, I've mentioned primary aldosteronism, and that's important because it turns out that if you look at patients who are in a specialist hypertension clinic, which are, of course, a particular type of patient, then primary aldosteronism, or PA, is particularly prevalent. It accounts for something like 15% of the patients who attend a hypertension clinic. I said they're a kind of selected group of patients. They tend to be younger patients, patients less than 40 years old, patients with more severe hypertension, patients who've had resistant hypertension. Those are the kinds of patients that we see in our specialist clinics. And in those patients, something like 15% appear to have primary aldosteronism. And that's an important thing to look for, because if they have it, then there are specific things you can do about it. You can do surgery in some cases, or a specific medical therapy. So on this diagram here, we've got the surgically curable on the right and the surgically not curable on the left. And essentially, the surgically curable causes are unilateral causes. So basically, where you've got an aldosterone-producing adenoma in one adrenal, then that's potentially surgically curable. You may have bilateral adenomas, but the overactivity may be on one side only, and the other adenoma may be an incidentaloma, which is actually fairly common. And there are other rarer causes, such as multinodular unilateral adrenocortical hyperplasia, and these down here, which are quite rare. But essentially, if you have disease with overproduction of aldosterone on one side, then potentially you can excise that adrenal, and that can, in principle at least, either cure or ameliorate their hypertension. And then on the left-hand side here, we've got the not curable by surgery causes. So here we've got bilateral adrenal hyperplasia. Here we've got a unilateral adenoma, but concomitant with that, we've got bilateral hyperplasia as well. And then we've got the familial forms of hyperaldosteronism at the bottom here, which includes type 1, which is glucocorticoid remediable aldosteronism. And all of these would not be amenable to surgery. So this is a kind of simplified algorithm for how you'd work up for the presence or absence of primary aldosteronism. And the key test here is the ARR, the aldosterone to renin ratio, because here what you would have is a low renin with a high aldosterone. The renin is suppressed because of the autonomous production of aldosterone. And what we would normally do is do an aldosterone to renin ratio in your patient in their resting state, but not necessarily withdrawing their drugs in the first instance. It's quite useful to do it, whatever drugs they're on. There are some drugs which will interfere more than others with the ARR, particularly spironolactone, and it probably isn't worth looking at the ARR in somebody who's on spironolactone. But for pretty much all other drugs, it's worth doing an initial aldosterone to renin ratio. And if that's normal, then that makes primary aldosteronism pretty unlikely. If it's markedly elevated, it makes it very likely. For a lot of patients, it's somewhere in between. It's a little bit high, but not markedly high. And what we tend to do in those sorts of patients is to repeat the aldosterone to renin ratio under more standardized conditions. And that means bringing them back, taking them off their drugs for a few days so that you have no interference with other drugs, and then you'll repeat it. And if it's still elevated, then you'll go on to the next step, which involves imaging, either with CT scanning or MRI scanning these days. And then if, depending on what that shows, if there's bilateral adrenal hyperplasia, then you'll go down the medical side. If there's unilateral disease, it then comes to the question of, does your patient want to have surgery or not? And if they potentially do, then you'll go down this side. If they don't, again, you'll go down the medical side. If they are potentially interested in surgery, then that's where adrenal vein sampling would come in. So what you then do is send them to interventional radiology, where they'll introduce catheters into the adrenal veins, take samples to measure the aldosterone to cortisol ratio on each side. And essentially you have unilateral disease if the aldosterone to cortisol ratio is elevated on one side. And if they do indeed have unilateral disease, then you can go on to surgical treatment, which these days usually involves laparoscopic adrenalectomy. Adrenal vein sampling, of course, is an invasive technique, and it's actually quite difficult as well, especially cannulating the right adrenal vein is very tricky, and a lot of even highly trained radiologists find that very difficult to do. So there is a search on for more non-invasive ways of identifying aldosteronism by imaging. And this is one particular technique which has come to the fore in recent years. This is called 11C Metomidate scanning. So this is PET scanning using carbon-labeled Metomidate. Metomidate was originally used as a veterinary anesthetic, but it also turns out that it inhibits certain enzymes in the steroidogenic pathway. It inhibits CYP11 beta 1 and B1 and B2. And essentially it gets concentrated in areas where aldosterone is being synthesized. And this here is a scan of a patient with a right adrenal adenoma that's producing aldosterone. So you can see on the CT scan here, there's the adenoma, and here it shows up on the PET scan, and this is the PET and CT overlaid. So this is confirming the presence of an aldosterone producing adenoma in the right adrenal. This is still an experimental technique. It's not yet in clinical practice, but it's showing great promise, and it may come to the fore in clinical practice in years to come. So how successful is surgery in these patients? Well, this is a study that was published in 2017, looking at the cure rate following unilateral adrenalectomy in primary aldosteronism. And essentially, the bottom line is it varies from one study to another, but overall, the cure rate is something like 50%. Which doesn't sound very high, really. You'd expect it to be higher than that. And why is that? Why is it that we don't get more cures when we excise the adrenal in question? And I think there's a number of reasons for that. First of all, it may be that the diagnosis is not correct. It may not be primary aldosteronism. It may be an incidentaloma, as I referred to before. It could be that there's underlying bilateral adrenal hyperplasia. So even though there's a nodule on one side, there may be bilateral hyperplasia that hasn't been detected by scanning. Or it may be that the PA, the primary aldosteronism, has been going on for quite a long time. And as a consequence of that, you've had significant vascular remodeling, so that by that stage, the hypertension is not so easily reversible. Or, of course, your patient may have, as well as their PA, they may have underlying primary hypertension. We know that primary hypertension is quite common, about 30% of adults have it, and so it wouldn't be uncommon for a patient to have both, to have PA and to have primary or essential hypertension. So about 50% cure rate, so you can expect things to get better, but may not necessarily be cured. Blood pressure may not return to normal. What about phaeochromocytoma as underlying cause? Well, that's much rarer. It's around 1 in 1,000 to 1 in 10,000 of the hypertensive population, equal gender incidence, commonest in the 3rd to the 5th decades of life. Is it worth investigating all our patients for phaeos? And I think the answer is no, because the pickup rate is vanishingly small if you just do it in all hypertensives. I think it's certainly worth doing it if there's underlying clinical suspicion of a pheo, so where a patient has signs or symptoms of excess adrenergic drive, if they have tremor, sweating, palpitations, etc. If they have severe hypertension, paroxysmal hypertension, hypertensive crises, where there's refractory hypertension, where they're on more than 4 drugs and still not responding, Where they have labile or postural hypotension, which is another important feature in phaeos, and where an adrenal lesion has been found on imaging. In those sorts of patients, it may be worth screening for phaeos. And what is the test that you should do? Well, various tests have come and gone over the years. The current one that's favoured is plasma metanephrines, for the simple reason that it's the most sensitive. It has something like 99% sensitivity for phaeos. It's not necessarily the most specific, though. That probably belongs to urinary catecholamines and metanephrines. But the specificity is not terrible. It's 89%. But it's the most sensitive. And so that is the test that most people would do these days as a screening test for phaeochromocytoma. So if you have a clinical suspicion, so you can do 24-hour urines, or these days probably go straight to plasma metanephrines, which is what most of us would do, whether the clinical suspicion is high or low. If your plasma metanephrines are normal, if the patient is having episodes of episodic hypertension, paroxysmal hypertension, or episodic spells of adrenergic overactivity, then it's worth rechecking the metanephrines during an episode of that. If that's normal during an episode, then it's worth investigating for other causes. If the plasma metanephrines are high, then you would go on to scanning, which could be MRI or CT. And you would also consider MIBG scanning. So in MIBG, which stands for meta-iodobenzyl guanidine, this is a type of scan using radio-labeled iodine, and MIBG is localizers in areas where the uptake 1 mechanism is active. So phaeos will tend to take up MIBG. Importantly, however, a negative MIBG scan does not exclude a phaeo. About 20% of phaeochromocytomas are MIBG negative. So the presence of a negative MIBG scan does not exclude a phaeo, but a positive one is a very good confirmatory test for a phaeo. It can also be quite useful if you've got extra adrenal phaeochromocytomas as well, because it can enable you to localize them more effectively. And then if a tumor is found, then you proceed to adrenergic blockade and surgical resection. What about these patients? How do they do after you excise their phaeo? Well, this is quite an old study now, but I think it's still quite relevant. This is a case series of 129 patients who were followed up long-term after phaeo resection. And of 98 patients who are alive without a recurrence, 70 were hypertensive at the initial diagnosis. And at 5 years, 74% of those were free of hypertension. By 10 years, it had gone down to about 45%. We're seeing a similar thing that, again, it's not necessarily a recurrence of phaeo, but it's probable that a large number of these patients also have coexistent primary hypertension. And so the longer you follow them up, the more of them develop hypertension over time. What about renal artery stenosis? Well, the weight of evidence suggests that really all other things being equal, it's one of those things that even if the patient's got it, treating it is not necessarily going to help very much. There are certain situations where it may, but in the majority of patients, all other things being equal, medical therapy will do just as well as renal artery revascularization. This is data from the ASTRAL trial from about 10 years ago. So they looked at patients who could, with renal artery stenosis, where there was no particular indication for revascularization, and they were randomized to either revascularization or medical therapy. The primary endpoint was renal function, as shown on the left here. We've got the reciprocal of serum creatinine up here and serum creatinine itself down here. And you can see absolutely no difference between the two groups. The medical therapy group and the revascularization group did exactly the same over time. In terms of blood pressure outcomes, again, no difference with time. Systolic pressure up here, diastolic pressure there, no difference between the two groups. First renal event here, first cardiovascular event on the bottom left, and on the right-hand side, overall survival. None of these differed at all between the two groups, medical therapy on the one side or renal artery revascularization on the other. So broadly speaking, I think we can say that renal artery revascularization is not beneficial and so not worth intensively investigating for. There may be certain limited situations where it is useful. So where somebody's had only a short duration of blood pressure elevation prior to the diagnosis of renal vascular disease, in that situation, it may be helpful. Where you've really exhausted all medical options, it may be helpful to try renal artery revascularization, because buried within the trial population, there are likely to be those who did respond as well as those who didn't respond. Patients who can't tolerate medical therapies for one reason or another, or patients who are on ACE inhibitors or ARBs, but whose renal function deteriorates because of renal artery stenosis. If you correct the renal artery stenosis, then they can usefully then receive their ACE inhibitor or their ARB. In patients with recurrent flash pulmonary edema or refractory heart failure, and also in those patients who have, as a cause of their renal artery stenosis, fibromuscular dysplasia, there's not so much evidence there, but what evidence there is suggests that in those kinds of patients, there may be more of a benefit. Briefly on to device therapies. These are some of the ones that are currently being investigated. None of these have yet been incorporated into the clinic. Renal denervation or renal sympathectomy has been around for quite a few years now. And it was in vogue at one time. And then along came the Simplicity Hypertension 3 trial, which basically showed it made no difference compared with sham denervation. Since then, however, technologies have progressed. We've got different types of catheters, and we've got better technologies in general. And there are still trials that are ongoing with renal denervation therapy. And here's an important one that was published earlier this year. This is the SPYRAL HTN-OFF MED trial. The pilot trial was published about 2 or 3 years ago. This is the pivotal trial with larger numbers of patients. So these are patients who are not on therapy or who were on therapy and then taken off medical therapy. And they were randomized to receive either denervation or sham operation. And these were the results. On the left here, we've got changes in 24-hour systolic and diastolic pressure. And on the right here, we've got change in office systolic and diastolic pressure. And you can see that here, there was a difference in favor of the renal denervation procedure. There was a reduction in 24-hour blood pressure of around 4/3.1, and a reduction in office blood pressure of around 6.6/4.4. There is an ongoing SPYRAL Hypertension-OFF MED trial. The pilot trial was again published a couple of years ago. Again, looks good. It looks optimistic, very similar blood pressure reductions. We don't yet have the pivotal trial published. And here's baroreflex activation therapy. This again has been around for a few years now. The idea is that you implant a pulse generator connected to leads, which goes into your carotid sinus, and then this can pace your carotid sinus, which then feeds back to the brain stem. And as a result of that, you get a reduction in sympathetic outflow and an increase in vagal outflow. And that the trials so far do suggest that can effectively reduce blood pressure. This is a meta-analysis of the available studies that was published in 2018. And essentially, the overall result shows a reduction of around 20 millimeters of mercury in systolic blood pressure and around 10 millimeters of mercury in diastolic blood pressure. And it seems to work in the short term, in the midterm, and in the longer term reasonably well. There are some caveats to this, though. All of the trials, well, most of them are quite small. They're very small. They're pilot studies. There's only one randomized controlled trial within all of that lot. And so there is a risk of bias in the data. So it's looking very promising, but again, it's not quite at the stage yet where it can be used routinely in the clinic. So to sum up, lifestyle with or without antihypertensive medications remain the bedrock of hypertension treatment. Spironolactone is the preferred add-on to triple therapy if the potassium is normal. Otherwise, if the potassium is high, alpha or beta blockade. Primary aldosteronism is common in patients with resistant hypertension. Phaeos are much less common. There's no convincing evidence that treating renal vascular disease helps hypertension control, except in certain specialized circumstances. And finally, to say device therapies remain experimental at present, and renal denervation is probably the closest to the clinic, but there are still a number of caveats with it. And that's my presentation, so thank you very much.
A question for Professor Cheung. Bernard, would you say something about how you give healthy lifestyle advice in practice?
I do mention salt restriction, mainly because it's actually fairly easy to do. I think soy sauce and the sauces really are the main source of sodium. And of course, the other thing, of course, is to choose the kind of meat that you eat. So obviously, hams and bacon and such like will be, cured meats will be high in sodium. So go for sort of fresh cuts of meat and also fresh vegetables as well, because the preserved vegetables will contain a lot of salt. And of course, the ubiquitous soy sauce. So just use less of that. And in fact, nowadays in restaurants, in the olden days in restaurants, you get a small dish of soy sauce. But nowadays, very few restaurants offer you that, which I think already is a good heading in the right direction. But it is striking, that amongst our patients, there's a huge variation in their sodium intake. I used to do that on all my new hypertensive patients, ask them to do a 24-hour urinary collection. I don't do that anymore. And in fact, we have even, over the years, we have identified the top 10 foods which are quite high in salt. And as expected, they're mostly sort of fast food items, and also the instant noodles, which are actually quite high in sodium. And it's interesting that we've known this for 15, 20 years, but every couple of years, the newspapers will publish another quote unquote studies telling people that instant noodles are high in sodium. So, but that's one thing, the sodium intake. But by far, the most effective way to lower blood pressure in terms of lifestyle intervention is to lose weight for those people who are overweight. And let's say in the course of 3 or 6 months, if they can successfully lose a few pounds, then the blood pressure will be better by a few millimeters of mercury. And that's, let's not underestimate that. That's equivalent to, one fewer antihypertensive pill. And we do see that, that blood pressure is easy to control if they can successfully lose weight. Even if they can't, the exercise in itself, regular exercise itself, would also help their blood pressure. So I think, I think it's good to get them into a virtuous circle, virtuous cycle, and also, patient empowerment, empowering them to, take their disease condition in their own hands, so that they feel that there's something they can do, that they're not helpless, there's something they can do to control their blood pressure, other than just taking pills.
Bernard, we do have a question from Owen Crawford.
Hello, thank you, Professor. My name is Owen. I'm a medical student at Cambridge University. I don't know how I came across this talk actually, but it's somehow got through to me. Thank you very much for your presentation. My question is about, I've got to stop my video. Okay. So my question is about plant-based diets. They're quite big in the media at the moment at reducing the risk of hypertension and all sorts of other cardiovascular health conditions. I don't know, because you said lean meats are better than other kinds of meats, which is fair enough. But I wonder whether you would take the next step further and eliminate all meat. I don't know to what extent these Netflix documentaries that talk about this are actually evidence-based. I sometimes sense that they are going for specific professors who might be a bit wackier than most. but I don't know how reliable they are in their information. So I'd be interested to know your opinion.
Yes, well, thank you, Owen. It's really an excellent question. I didn't speak specifically about vegetarian diet because it's already part of the sort of DASH diet concept. So, I mean, it's well recognized that fruits and vegetables will help your blood pressure. But since it's part of the, DASH diet, and that's why I kind of did not list it as a separate category. Now, I have to be very careful about my remarks because I've just reviewed a meta-analysis on plant-based diet. So I must be very careful not to, not to give away, the conclusions of that meta-analysis before it has been accepted for publication. But the evidence is very impressive. So overall, you can expect to lower blood pressure by, let's say about 5 millimeters of mercury with a plant-based diet. So again, that's as good as one antihypertensive drug. Now, I mean, having said that, if somebody wants to be vegetarian anyway, and they try the vegetarian diet, fine, that's great. On the other hand, I wouldn't preach that, patients must go on a vegetarian diet and give up meat in order to be saved. It's not, you don't need to be as drastic as that. But certainly there are better cuts of meat than others. So one should really go for the leaner meats. I have no objection to, lean chicken and fish, for instance.
We have a question from London from Wendy French. I think it's directed to Albert. Wendy's question is, what about people from more socially deprived backgrounds in whom you're asking them to have healthier diets, which may be more expensive to buy?
I think the point is well made that for a lot of people, it can be quite expensive to change their lifestyle in the desired way, to go with the kinds of diets that we've heard about, which can be quite expensive. And actually, adherence to those sorts of things can be quite difficult as well. It's very difficult to change the way you eat, the way you exercise, all of those things, unless you're really motivated. And a lot of people come to the clinic and say, well, I'm not going to do any of that, doc. Why don't you just give me a tablet? And that's a fairly understandable reaction, I guess. I think it's always worth giving the advice. And if there's no particular rush, if they're all their risk over the next few months, year or so is not that high, I think there's nothing to be lost in asking them to do their best at least. And if they're not getting anywhere, then you can think about going on to drugs. I think it's important to not over-medicate people if you can help it, because although we know the drugs are effective, we know that that we get good outcomes. They are associated with adverse effects as well. We know that about 50% of patients will stop taking their drugs after 6 months. And so, yes, they have a definite place. Drugs do have a definite place. But I think we really should try and stick to the guidelines. It's worth patients doing what they can, trying to be a bit healthier, maybe drinking a little bit less, maybe cutting a little bit on how much salt they put in their diet, and then reviewing in a few months. So I would always go with lifestyle first.
Thank you. Thank you.
Thank you very much. Andrew Schindler, you had a question for Bernard on Mediterranean diet. You there, Andrew?
I believe in the Mediterranean diet, moderate amounts of cheese are allowed. I assume all these Italians, French and healthy Spanish people are not just having cottage cheese, they're having some nice local cheeses. Just wondered what your take was on that and how much can we have?
Well, I have to say I'm no expert on cheeses. And I also suspect that, for people who do eat cheese, it won't be just one kind. They'll eat, if you think about the cheese board, they'll eat, several kinds of cheese at once. Now, I was talking about the American DASH diet earlier on, and in DASH, they're very clear about, banning high-fat cheeses and advocating low-fat cheeses such as cottage cheese and so on. those are the Americans. I think Europeans are probably enjoy their cheeses too much to give up, their favorite cheese. I think somebody else asked me about brie. So I guess is well, and also one can always eat what one enjoys, but don't eat it to excess. So I suppose, as you said, Andrew, that by all means eat what you enjoy, but make sure that it's in moderation. And also there's the diet with a rather long name, lacto-ovo-vegetarian diet, which allows you to eat dairy products. And that's actually quite, there are studies showing that it's actually quite successful in getting the blood pressure down. So, and of course there are the ketogenic people who would only eat the cheeses with the highest fat content, to get them into ketogenic mode. So that, also works, probably largely to help you to lose weight very fast. So I suppose the long and short of it is that, yes, you can eat different kinds of cheese. There are different schools of thought, but I suppose ultimately it's really the amount that you eat that matters.
Thank you very much for your question, Andrew. Thank you, Bernard. Just to add, at one of the earlier meetings organized by the Healthy Heart Charity, the Cardiovascular Research Trust, Ramon Estruch spoke. He's from Barcelona and ran a study on primary prevention of cardiovascular disease based on the Mediterranean diet, Spanish style, which was published in the New England Journal of Medicine in 2013. And what was interesting was lots of mechanisms, reasons, which have been postulated why the diet may have worked, why in Spain may have helped to reduce heart failure, other complications, stroke, but also dementia. And one of the observations was comparing, advising people to be healthier and to lose weight versus Mediterranean diet. Weight loss was a remarkable observation. So not focusing on the weight, but going for a better diet, in fact, was more successful getting weight reduction, which we've already heard from you, Bernard, is a good way to get blood pressure down. So I have a further question, I think both for Albert and Bernard. And Albert touched on this. What you may get from patients in the clinic is, well, I've tried all this, cutting alcohol, weight loss, salt reduction. Blood pressure is still too high, according to my GP. I've come to see you in the clinic. And now you're giving me some tablets. Can I forget about these lifestyle measures? So my question really is, what's the evidence that continuing with lifestyle measures will make a difference to the effectiveness of medical treatment or ability to reduce the number of tablets you might need if you keep going with these lifestyle measures? Perhaps you want to answer first, Bernard?
Oh, well, that's a good question, because most of these lifestyle modification trials are done on people. Actually, the lifestyle measures work better in those who are hypertensive rather than normotensive. So if your blood pressure is only slightly elevated or in the normotensive range, these lifestyle measures affect your blood pressure relatively less. So yes, there is such evidence. But on the other hand, as you said, it's much easier to take one additional pill or to take a higher dose than to institute all those lifestyle changes.
Anything to add to that, Albert?
I would add that I've had a number of patients, so this is anecdotal, who I've put on medication, who have then gone away, lost lots of weight. They've been very motivated. They've done lots of exercise, and their blood pressure has come down to normal, and they've been able to come off antihypertensive treatment. So I think it is definitely possible for that to happen. I'm speaking anecdotally, but I'm fairly convinced that does work.
And they said from published studies, for example, Australia, in younger males particularly, cutting alcohol can be quite successful in getting people off the diagnosis and avoiding the need for future treatment. But again, it depends on severity, I think, and how long blood pressure has been there for. I have a question next from Wade Dimitri. Wade?
On the question of alcohol, I've heard that talk from the professor from Barcelona, and he added that adding good wine to the Mediterranean diet was very helpful. I've got two questions, actually, one for Bernard and one for Albert, and thank you very much for your presentations. From a surgical point of view, I really thoroughly enjoyed it. For Bernard, given that increments of 10 millimeters of mercury, either systolic or diastolic, can take you from, say, mild to the next degree of hypertension, and given that there are diurnal variations in blood pressure, apart from the white coat syndrome, there are a lot of studies with lots of patients who put a lot of emphasis on either factors that give you hypertension or the effect of reduction of hypertension for treatment. How can we be certain that the methods of measuring the blood pressure are uniform throughout these studies? So that's the first one. And the second one to Albert, given that the management of renal artery stenosis now is so, it's not surgical, it could be simple by stenting, why wouldn't you stent all these patients with renal artery stenosis, and then, you know, hopefully the hypertension will get better?
Well, thank you, Wade. Question for you, first of all, about how you standardize blood pressure measurement, the office, the ambulatory, and so on.
You know, in controlled studies, because they're in randomized controlled trials, because the same method of blood pressure measurement is used on both arms. So even if there are variations in the technique, it should even out because of the randomization process. And what else? Well, also increasingly, most studies on hypertension done in the last, let's say, 5-10 years would involve ambulatory blood pressure measurement. Again, that has been shown to be more accurate than you know, measuring the blood pressure in the clinic setting. Now, as for home blood pressure, there's no quality control at all. It's very good for routine practice, but I mean, I'm not sure how good blood pressure monitoring is for research studies.
And Albert, on this point about what about stenting people with renal artery stenosis, just doing it, do you want to say a bit more about the trials and the evidence,
yeah,
benefit or not?
Sure, of course. So Wade, the trial I'm referring to, the ASTRAL trial, revascularization was mostly by angioplasty plus or minus stenting, and essentially that was showing that it makes no difference. So it's kind of saying there's no point subjecting a patient to angioplasty of their renal arteries unless there are certain well-defined situations, because it's not going to make any difference.
Well, on that very practical point, I'd like to thank both our speakers for an excellent session. As I said at the beginning, this is the first of a series of monthly webinars addressing different cardiovascular risk factors and ways to consider how best to investigate and treat a range of disorders of heart, brain, and circulation. You can find out how to register for these free webinars by going to the website of the Cardiovascular Research Trust, healthyheartcharity.org.